our studies included only 3 of our studies included any follow-up after the active intervention phase, and that ranged from 3 to 12 months. And when we're looking at risk factor or chronic disease management, we know that the importance of long-term monitoring and management that come with that. So it really kind of invites, where do we go from here? So our initial thoughts with our study was essentially as a proof of concept for us to then develop our own type of chronic disease self-management programs. The current coronavirus situation being what it is, those plans are currently stalled. But we do know that more research is needed regarding how to integrate risk management into existing physical therapy intervention, and in particular for those individuals that have more severe deficits. And we know that physical therapy is very well positioned to address stroke risk factors into current practice. In fact, we might be one of the let me see how I phrase this diplomatically. We could be a key discipline in not only addressing the functional deficits that persist post-stroke, but being able to adapt chronic disease self-management protocols and programs into our existing treatment protocols. So whether that's teaching patients how to self-monitor vitals, or how to read lab results, which I know that Gina will talk more about with her case study. But we're really, I think, poised to be an important component, particularly for individuals who do have functional deficits within a broader health and wellness picture. And we're doing ourselves a disservice by not publishing about it more frequently than we are. And we know that these patients have multiple needs, and our patients are only getting more complex. So finding better ways to integrate some of that complexity management into existing protocols is really the way to go. So let's see. So I'm a few minutes ahead of schedule here. But so these are the 12 articles that we included within our study. They're available. Our manuscript is, I believe, still currently available ahead of print on the website and should be in print shortly. I have additional references as needed. And then at the end of today's presentation, happy to entertain any additional questions or discussion.
All right. Thank you, Dr. Sutton. So now I'm going to introduce Gina Pariser is a faculty member in the Doctor of Physical Therapy program at the Bellarmine University, Louisville, Kentucky. At Bellarmine, she teaches courses in exercise physiology, health promotion, and research, and mentors students in service learning. Gina is a licensed diabetes educator. She developed and co-directs with colleagues an interprofessional service learning clinic called Active Steps for Diabetes. Active Steps for Diabetes is a comprehensive education and physical activity program for people with diabetes and mobility limitations. It is held at a community center serving a diverse patient population. Gina currently serves as a chair of the Health Promotion and Wellness Special Interest Group at APTA Geriatrics. Welcome, Gina, who will be presenting our case study today.
Thank you, Katie, and thank you, Susan. Share my screen. Can you see my screen?
Yes.
Glad to be with you this evening and to share a case example related to Katie's work. And the title of it is A Walk to Wendy's, the role of PT in chronic disease management. And the case is specifically somebody with who is a stroke survivor. Katie was in Kentucky for her PhD, and we have fast horses and high rates of diabetes here. Katie, in her first slide, talked about their large database that shows a large percentage of stroke survivors with hypertension and diabetes. Studies from the National Health and Nutrition Survey also not just look at percentage, but look at the percentage of people who have uncontrolled hypertension, meaning blood pressure is greater than 140 over 80, and uncontrolled diabetes using an A1C. An A1C of 7% is considered diabetes. Uncontrolled, they define as greater than 8%. So in looking at stroke survivors in these databases, greater than 1 in 3 stroke survivors have uncontrolled hypertension and 50% have uncontrolled diabetes. There are several studies too looking at average strokes per day in average steps per day in people with chronic stroke. And the numbers are very low, with 5,000, less than 5,000 being considered sedentary, and this decreasing with aging. Our case description is about a 68-year-old African-American male who had a left CVA, ischemic stroke, 5 years prior to enrolling in a 12-week diabetes self-management training program called Active Steps for Diabetes. It's delivered by an interprofessional team in which PT plays an integral role. The patient presented with slight increase in tone in the right upper extremity and a little bit of synergistic movement of the right elbow, wrist, and hand. A slight increase in tone in the right lower extremity. So when he walked, ankle was either plantar flexed or neutral. He used a cane. He could climb steps using a step 2 pattern. He had mild aphasia, certainly could communicate, but sometimes had trouble with word finding and conversations that were complex, needed to be broken down and occur at a slower rate. Other conditions, peripheral arterial disease and benign prostate hyperplasia. His BMI was 27, so he was overweight but not considered obese. His blood glucose was 10 or HbA1c, a measure of blood glucose levels, was 10.1%. Again, anything over 8% is considered uncontrolled. His resting blood pressure was 172 over 85. He had uncontrolled blood glucose, uncontrolled hypertension, despite being on multiple medications for those conditions. His diabetes medications were oral medications. He was not on insulin. His hypertension medications included a diuretic, an ACE inhibitor, and a calcium channel blocker. He was sedentary and had a poor diet. He ate breakfast or lunch every day at Wendy's. He drove to Wendy's to meet his friends there while his wife was at work, and she worked as a certified nurse assistant. She expressed frustration with his lack of motivation for being physically active and to eat better. She talked about that they used to travel some and dance before his stroke. He won't do that now because he gets winded and he is afraid he will have a heart attack or another stroke. He also expressed fear of having another stroke with physical activity. Interventions in the Active Steps for Diabetes program. Nursing consulted with the participant's primary care physician on recommended medication changes, given the fact that of that numbers were not in control. And because of the synergistic movement in the right upper extremity, he talked about some difficulty with buttons. He also had difficulty testing his own blood sugar. So PT and nursing together worked to find a lancet that's a single-use lancet with retractable needle, and positioning hand and forearm in weight bearing to improve his dexterity and his ability to test his own blood sugar levels. PT intervention also included physical activity, goal setting, and motivational interviewing. In the interviewing, we learned that the Wendy's restaurant was 5 blocks from his house, approximately 500 meters or 0.3 miles. He talked about that friends walked there. They walked by his house when they walked there, and he would like to be able to do that as well, but that he got winded just walking to the mailbox. So he set the goal of walking to Wendy's. His wife had mentioned dancing in his initial 6-minute walk test. His distance was 260 meters. He stopped briefly to rest twice at 1.5 and 4 minutes. So one of our doctoral physical therapy students that was working with him taught him that one song was 3 minutes long and that he had walked 2.5 minutes without stopping. And she thought that he could dance a 3-minute song with his wife and encouraged him to also make that as a goal. The approaches that we used for this patient for a physical activity prescription and promotion were the whole of day approach and the graded activity approach. There are many approaches. Whole of day approach focuses on reducing sedentary time and increasing light activity rather than focusing on accruing 30 minutes of moderate intensity physical activity per day. And the whole approach a day is thought that it might be more acceptable and ultimately more successful, particularly in individuals who have a history of inactivity and have mobility limitations. So in this approach, the participant used a Fitbit and an egg timer to incorporate this approach. The Fitbit was used to set goals for number of steps per day. So started out looking at what his average steps per day were and then gradually increasing, setting goals to increase that. The egg timer was used to cue the participant to do intermittent bouts of light activity during prolonged sitting. He watched TV some, and then other times he just talked about that he just sat. So we encouraged him when he was sitting, when he knew he was going to be sitting for a long period of time, to put the egg timer next to the chair and to interrupt sitting with bouts of standing and light activity. The 2016 guidelines, the newest guidelines for exercise and diabetes from the ADA, recommends prolonged sitting be interrupted with light activity. That light activity can be in sitting or standing. For 2 to 3 minutes out of every 30 minutes. And that has been shown to improve blood glucose control if in an 8-hour period of prolonged sitting to interrupt that with activity every 30 minutes. The graded activity approach was also used, and that approach incorporates both principles of exercise physiology and cognitive behavioral therapy to address psychological barriers to physical activity. In this case, the individual talked about that truly a major barrier for him was fear. He did get the mail each day, but feared doing more activity than that. In this approach to the physical activity that you utilize is consistent with the patient's goals, and dosage is going to be based on a quota rather than exercising to tolerance. To set the initial quotas, you have some sort of baseline measurement of their exercise tolerance, and you start at about 75% of that. So what we did is, one, we chose walking because as the activity, because his goal was to be able to walk to Wendy's, which remember was about 500 meters away. His initial 6-minute walking distance was 260 meters in 2.5 minutes without stopping. So our first quota was to walk for 2 minutes, and we took also 75% of the 260, so it was around 195 meters. So it was to walk 2 minutes and then have active or passive rest period for 2 minutes, and repeat the 2 minutes of walking, 2 minutes of active or passive rest period until he had achieved a total of 196 meters. And that was gradually, the quotas were gradually increased over time. Meeting quota was followed with lots of praise. Not meeting quota was followed with discussions of the importance of the activity, talking about barriers and facilitators, so some motivational interviewing. Looking at our pre and post outcome measures, you'll see that he started with a resting blood pressure of 172/85. Is still hypertensive at the end of the program, but much better in a 12-week period. We can't just attribute that to activity alone, because again, we talked about nursing is part of this program and works with the physicians on medication management. But I will share, there is kind of a neat trial called the Breakup stroke trial that involved people with chronic stroke, and involved using the whole of day approach, specifically breaking up sitting with intermittent light activity every 30 minutes during an 8-hour day period. And that study showed doing that, just sitting less, standing a little bit more, the average blood pressure decrease was about 4 millimeters of mercury, ranging from around 3 to about 7. So again, using that approach can have a positive effect in lowering an individual's blood pressure. HbA1c decreased from 10 to 8, still not in control, but much better, much better. Some diabetes educators that I work with, when they talk about people as they age, if they're at risk for falling, although we think of 8 as still being out of control, they're also concerned about individuals' blood sugars getting low and them falling. So diabetes educators I work with are happy with that decrease that we saw in this individual. Body mass index did not change. Look at steps per day. He had an average of a little over 3,000. Again, less than 5,000 is sedentary. Afterwards, he would be called in the category of somebody who does light activity. Gait speed, slow. Gait speed improved. 6-minute walk distance improved. We also looked at tug time. We also use a outcome measure called a modified physical performance test, and that's a 9-item test that includes stair climbing, putting a jacket on, taking it off, turning 360 degrees, walking speed. In the modified physical performance test, you have a total score that classifies levels of frailty. So he would have been defined with the initial score of 17 as moderately frail, and the range for moderately frail is 17 to 24, and then above 24, the next category is mild frailty. So still defined as moderately frail, but a significant improvement within that category. So one of the things that we're doing with Journal Club and having the article presentation and talking about how we apply that. Again, applying what Katie talked about, looking at chronic disease management, involving family in that. And one of the things that this is obviously somewhat of a unique program, but I want to talk about how maybe if you don't have access to that kind of program, what you can do to implement chronic disease management in the clinic and the care of your patients. I strongly encourage you to make clinical community connections that help stroke survivors to be physically active and manage health conditions after discharge. In recognition for the need for accessible community-based exercise programs for stroke survivors, some YMCA, some Silver Sneaker programs have developed programs specifically for stroke survivors that follow American Heart Association guidelines for aerobic and resistance exercise for stroke survivors. Those are still can be hard to find those programs unless you're in large metropolitan communities. The other thing that you can readily find is the diabetes prevention program. Most public health departments, many YMCAs offer the CDC diabetes prevention program. Would strongly encourage you to find those programs and refer your patients to them. It's a 16-week program. It meets once a week. It's often led by a nurse. It does not have actual physical activity, but lots of discussion about it, lots of focus on dietary habits, and well-researched, evidence-based program. And people don't think about referring somebody with diabetes because it's called the Diabetes Prevention Program, but people with diabetes can enroll in those programs as well. It is actually also now reimbursed. Usually the cost is relatively low. Some places like your public health departments may offer it at no cost. But encourage you to look for diabetes prevention programs. So make those clinical community connections that can help your patients manage chronic conditions. The other is think about creating your own clinical community connections. Talk to your public health departments. Look in particularly if you have some interest in diabetes or programs they may be offering for people struggling with arthritis. And most of those programs have the standard discussion about physical guidelines for Americans, and they talk about the fact that 30 minutes can be broken up, but they don't have the expertise to individualize exercise for people with mobility limitations. And that's where your involvement, maybe if not directly working with participants in the program, at least giving a talk and making some suggestions for people with mobility limitations. Another thing, if you haven't seen it yet, check the August issue of Jerry Notes. Some folks at Johns Hopkins are working on a program, Staying Active After Stroke, a customizable community resource guide for stroke survivors. So take a look at their work. And as Katie talked about, assess your outcomes. When she looked at the literature, even the studies that engaged PT really didn't measure the effects of their education related to chronic disease management. You're likely talking to patients about that often. Have them in doing knowledge recall, document that your education was effective in increasing their understanding. If it's effective in increasing their self-management behaviors, document that. Document changes in numbers that physicians and nurses in chronic disease management are interested in. They're interested in blood pressure and blood sugar. Document that over time with your patients. So the proof is in the pudding, and we have that PT can play a really important role in chronic disease management. Thank you.
Thank you, Gina. There were a few questions in the chat box. One of them is for Gina. Does your interdisciplinary program charge a fee, and how do involved professionals get reimbursed?
My interdisciplinary program is unique in that I'm at a university. So, and we are doing it at a community health center with a lot of patients facing a lot of social determinants of health. So it is a part of a curricular requirement. There are at some hospitals in our area that have set up somewhat similar chronic disease management programs that are interprofessional. I don't know how those are reimbursed. As I said, I am familiar with that. The diabetes prevention program is reimbursed through Medicare.
Okay, thank you. This question is for Gina or Katie. What is available via PT telemedicine after stroke? Has anyone coupled PT chronic disease management with this kind of program?
I don't know the answer to that. And if there's somebody online doing that, I would love for them to share. I will tell you that because of COVID, our active steps for diabetes, we're working with that. But we don't at this time have a patient in the program who has chronic stroke.
All right. This question is for Katie. What outcome measures do you recommend PTs use regarding Cdsm goals?
So good question. So there aren't great outcome measures in this area that are easily implementable in clinical settings. So there are numerous, and I'll include a link in the chat for everyone. There are numerous health literacy scales that we've used before. I can tell you in clinical practice, a lot of these are impractical because they take a long time to fill out, and most of them are numeracy related. But I have used the Breathe Health Literacy Screening tool. It's not sensitive to change, but at least gives me a starting basis. It's only 4 questions. In terms of disease self-management, there is a self-efficacy for chronic disease self-management scale. It's only 6 items long. I've used in the past. I'm a big fan of using the goal attainment scale because it's patient specific, because they make up their own goals. So sometimes we'll include knowledge-based questions in those, like Gina says. We also, encourage if, I don't know if you have to be a member of the neuro section, but the Stroke Edge has a well-reviewed outcome measurement usage. The big piece that's really missing that would be an excellent research opportunity is a measurement of physical activity that doesn't involve independent ambulation. We really don't have great measures. 6-minute walk is as close as we kind of get, or estimations using pen and paper questionnaires, but that's a big piece that I'm always struggling with, I know, clinically, of trying to get some of those measurements with some patients who lack mobility but can still be physically active.
All right. So Gina, this question is for me. Did you use any specific outcome measures for education piece in your program, or did you do what you had said about just documenting that you did knowledge recall in the treatment notes?
Great question, Susan. And right now, the questionnaires available, there are 2 on knowledge of diabetes self-care. One, I think, is really too simple, and the other is somewhat complex. So for the most part, we just document in our treatment notes that they understand their disease, they're able to test their own blood sugar, they're able to measure their own blood pressure, they're able to interpret those values.
Okay, thank you. There's a couple more that came in. Let's see. Any knowledge about behavior change in stroke survivors with impact to their motivational centers in the brain? Some don't seem ready for behavior change, or it's just a caregiver who is ready for them to change.
Yeah, so this is, some of that is figuring, some of that is looking at some like readiness for change, trans-theoretical model, motivational interviewing type strategies. Others is trying to find things that do motivate patients. So kind of, what Gina speaks to in terms of, it's not just physical activity, it's not sittings, and trying to work with patients and especially caregivers that, physical activity doesn't just mean walking, and it can be meaningful activity too. And that's really where I think caregiver education and involvement comes into play, because if you've got one member of the family that needs to make behavior change, and we typically know that that's not the only member of the family that needs to do that as well. If you don't have buy-in from the family, then you don't make a whole lot of progress. So that's where, like I said, I use like the goal attainment scale a lot, because then at least I can give a patient and family members try to give them some autonomy and active involvement with their treatment plan. That helps sometimes.
Okay.
But
Okay.
That's a great question about change in motivation within brain centers, and I don't know the answer to that. I will say, specific to this patient, using a goal and working toward that to increase physical activity, that was his goal. Counted a lot for our success. We do some follow-up calls with our participants. So in follow-up calls with him, he's very happy. He walks to Wendy's once a day. Nursing and PT work together to reinforce making healthier choices. So he talks about that he still walks to Wendy's 5 to 6 times per day, makes healthier choices. A1C has gone down a little bit more. We ask, tell him that physical therapy can do more. And he says, no, I'm really happy with my activity level now. And he does stand up some. So we have had some success with continuing at least that level, that light activity level of physical activity. So.
Okay. And do you see any benefit to teaching the fearful client about signs of stroke or MI? I loved the idea of tying the length I dance with a song.
Yes, we do, and spend time talking about signs, and make sure that both the patient and family members are educated on that.
Yeah. Sorry, Gina.
Yeah, the American Diabetes Association too, if your patients utilize the internet, has kind of a neat program that, so working, it's combined with the American Heart Association and the American Diabetes Association, because often patients have both hypertension and diabetes in it. So it's called No Diabetes by Heart, and they can find resources there, recipes, physical activity information. If they sign up for it, we'll be periodically sent emails and with information that may be helpful to them in managing the chronic disease.
Mm-hmm. Yeah. Yeah, I'd add with that a lot of times it's the fearful client, usually that's coming out of a sense of helplessness or being overwhelmed. So I usually try to pair knowledge with action, so that, yes, like these might be the signs of a stroke, but here's what you would do, in those cases, or sometimes along with teaching. So if we teach, so I use actually, I used to work with active steps with diabetes with Gina. When I lived in Kentucky, we use a stoplight method for checking blood pressure, which is really easy visual for them to do, and it really demystifies the process. So a lot of that kind of fear, I think, sometimes is a sense of being overwhelmed, and sometimes that's meeting patients where they are. I've had patients who, have been sent to me with doctors telling them, well, you just keep having strokes till you die. And so we say, well, if that's going to be the case, you might as well be doing things you like and trying to get them, up and doing that. So a lot of times it's meeting patients where they are and not overwhelming them all at once.
That's great. Another question, Katie, how can we facilitate research on the sorts of stroke patients that PTs are actually seeing in the clinic? Poor balance, not independent ambulators, aphasia, depression, etc.
Well, one, we need more clinician researchers who see patients in the clinic to do research. But I think, a lot of that comes down to research design. So, when your outcome measures exclude the majority of our stroke population, there's one, we need inclusive research methods in order to recruit these patients. We have literature that says that patients with severe cognitive and mobility deficits can participate safely in research. It tends to be a few more IRB waivers that you need to present, but I think a lot of that is involving more caregivers, so more dyadic approaches as opposed to individual approaches, because that takes away some of the barriers related to maybe an aphasia or their communication deficits, and being able to tailor those interventions so that they're accessible no matter what level those patients are meeting you at. Essentially, I think we need research that better replicates just the clinic setting that we work in, because we see these patients safely every day. There's no reason why we can't also be collecting data from them too.
Right. All right. Anybody have any other questions? A couple of messages came in. Allison said, great answer regarding caregivers. Some evidence with persons with dementia in this regard. What do you think it would take to do that? I think that's to Katie.
I think sometimes that just involved, some of that we do a lot of multidisciplinary and interdisciplinary research where I'm at too. So it's sometimes finding the right partners and community partners so that we're not trying to tackle everything at once, are things that are more outside, better else in somebody's wheelhouse. You know, yeah, I mean, I think that there needs to be more advocacy in terms of who needs to be included in research.
All right, thank you very much. Great discussion. All right, so I don't see any more questions. If you guys have any other last minute, oh, there's someone said thank you to Katie. All right, so thank you for your attendance, everybody, and also special thanks to Gina and Katie. Our next Journal Club is scheduled for Tuesday, November 17th. So I hope everybody has a great night and see you in November. Bye, everyone.